So today's breast surgeon is a thoughtful philosopher rather than a simplistic cutter of the breast. So there has been a paradigm shift in breast surgery from mutilating mastectomy from the legend of Saint Agatha of Sicily to individual tailored breast conservation and oncoplastic techniques and multidisciplinary thinking. So margins. There is a paper from Pilecki and Monica Morrow from New York, and more than 500 patients with triple negative breast cancer were analyzed for 84 months, and there was no difference in local recurrence rate in the cohort of patients with margins of 2 millimeters and more ample. Effect of trastuzumab in HER2 positive patients. Also, the study from New York in early breast cancer after breast conservation and radiotherapy, and there was 7-fold increase in local recurrence rate in the cohort with no trastuzumab in HER2 positive patients in comparison with the cohort with trastuzumab. Excuse me, there's a busy slide, but there's a meta-analysis of more than 14,000 women by Husami from Australia and Monica Morrow from New York. And to summarize, the conclusion is that there was no need for more ample margins. There are no cancer ring in young patients, in patients with lobular cancer, in patients with unfavorable prognosis. But a positive margin as in non-invasive cancer and DCIS associated with at least a 2-fold increase in ipsilateral breast tumor recurrence, and this increased risk is not nullified by delivery of the boost by systemic treatment or favorable biologic subtype. And a very recent study from 2016 from the Netherlands Cancer Institute, more than 8,400 patients after breast conservation were analyzed for more than 20-year period with median follow-up of 9 years. And the main endpoint analyzed was local recurrence rate, and the cumulative 5 and 10-year local recurrence rate was low, like 2% and 5% respectively in the whole cohort of patients, and 4% and 9% in patients younger than 40 years old. And significant risk factors for ipsilateral breast tumor recurrence was young age, positive nodes, involved margins with DCIS, and factors associated with lower risk of IBTR were adjuvant chemo, adjuvant hormonal therapy, RT boost. And re-excision did not significantly affect the ipsilateral breast tumor recurrence rate when knowing a tumor. And it was in line with our study in my institution between 2009 and 2014. And local recurrence rate was low, like 0.23 in my institution per year. And local recurrence was diagnosed in patients with non-luminal A breast cancer despite wide surgical margins, especially if the patients did not receive adjuvant systemic treatment or radiotherapy was delayed or omitted. And there is a slide from St. Gallen Symposium from the Harvard Medical School. And as you can see, margin assessment has greatly improved. So there is a specimen in OR, like 4 millimeters margin. And there is a compression, a shrinkage when you put in a jar, the specimen in the path lab is like less than 1 millimeter. So pathology assessment should be fast and fresh. A next study from New York, there is a diagnostic tool MRI, and there is no association between perioperative MRI and lower recurrence rate in DCIS patients in more than 2,300 patients. And breast surgery dynamic era. So there is some recent studies from 2016, like Sperano et al. From New England Journal of Medicine, and more than 10,000 women were analyzed. and recurrence score between 0 and 10 in 21 gene assay predicts low rates of recurrence in a distant or local regional site with endocrine therapy alone. Epigenetics, also from 2016. Radiotherapy-induced microRNA prevents relapse of breast cancer in the proximity of the surgical scar. And immune factors like immune signatures, like tumor-infiltrating lymphocytes or immune checkpoints have made an impact on prediction of local recurrence rate. So, to conclusions. Aggressive subtypes like triple negative or HER2 positive have higher rates of local recurrence than other less aggressive subtypes like luminal A, but no difference in local recurrence for triple negative patients treated with risk conservation or mastectomy strongly suggests that bad biology is unlikely to be overcome with larger surgery. Although positive margins were highly correlated with local recurrence, and the impact of biology on local recurrence is mitigated by effective systemic treatment like anti-HER2 or like endocrine or chemo or targeted therapies or radiotherapy. And novel tools on the horizon. Association of genetic, epigenetic and immune signatures with local recurrence by validation is urgently needed. And last but not least, I would like to invite you to Poland, to Krakow in September. There will be Congress of European Society of Surgical Oncology in partnership with the Polish Society of Surgical Oncology. You're welcome. Thank you.